Good evening, all. Welcome to ISA online PG class. Today we have amongst us very respected Dr. Parashar and Dr. Pradeep Bhatia. Dr. Pradeep Bhatia shall be dwelling on an important topic on day-to-day clinical practice and critical care, how to restrain an agitated patient and the ethical and medical dilemmas associated with that. The coordinator for today is Dr. Parul Jindal. I request Dr. Parul Jindal to please carry on the proceedings. Unmute.
Good evening, everyone. Thank you so much, Naveen sir. We are indeed honored to have such esteemed speaker among us today. The topic for today's discussion, as we all know, is restraining of an ICU patient, which also has both medical and legal implications. Which patients to be restrained, which patients and what type of refrainment is required will be discussed today by our eminent speakers. But for such an eminent topic, we need to have an eminent speaker too. Chairperson too. May I now have the honor to introduce our chairperson for today. Dr. Pradeep Bhatia, sir, is head of the Department of Anesthesia at SD Memorial Hospital. He is a cardiac anesthetic and chronic pain management, a past president of ISCCM Jaipur and past secretary of ISCCM National. He has played an instrumental role in bringing DNP anesthesia to SDMH, the first private medical hospital in Rajasthan to have such a program in place. He's faculty in various conferences and workshops. He has more than 20 publications to his name. He has won awards like Times of India Wellness Award in Anesthesiology and Award of Excellence in Anesthesiology by the Association of Anesthetists. I welcome you, sir. May I now request you to kindly introduce our speaker for today.
Thank you, Parul. As I said earlier, Dr. Pradeep Bhatia is Professor Head of the Department of Anesthesia and Critical Care, All India Institute of Medical Sciences, Jodhpur. Although he doesn't need much introduction because he is very widely known to the faculty of anesthesiologists, and he is presently the editor-in-chief of Anesthesiology and Society Journal. And the topic today, which he is going to talk, is an important topic for the PG students. Restraining is actually is not a new thing, which has been practiced for centuries. And physical restraining was the earlier one. To talk about more in detail, I invite Dr. Pradeep Bhatia to give his views on the not only the methods of agitating restraining, also the ethical and legal aspects of restraining. Dr. Pradeep Bhatia, please.
Thank you, sir, for your nice introduction, kind words. Good evening, all of you. And I would like to thank the organizing committee of ISA to invite me to this PG assembly, PG class. And I love to treat and interact with PGs. And I hope there are not only PGs, but ISA senior members also. And I'll be, just a second. Yeah. So this is the institute where I'm working. This is All India Institute of Medical Sciences, Jodhpur. And we are managing 30 operation theaters in this institute and a 35-bedded multi-specialty intensive care unit, where we are managing all the medical surgical patients in the ICU and sometimes neurological patients and cardiovascular problems patients are also managed in this ICU. So our residents are getting all kinds of exposure, and we have started DM in critical care courses 3 years back. So we have 10 DM candidates at present, plus 5 more will be joining very soon. And I am working here. Yeah. Am I audible? Yeah.
Yes, sir, you're audible, sir. I request all the audiences to mute yourself while the lecture is going on. You can post your queries in the chat box, which will be taken by the speaker at the end of the session. And the session has been streamed live and it is available on YouTube, and it has been recorded also. Thank you so much, and I'm so sorry to disturb you, sir.
No problem. So in this institute, I'm working as a professor and head of the Department of Anesthesiology and Critical Care. And as introduced by Dr. Parashar, I'm also editor of Journal of Anesthesiology and Clinical Pharmacology and a founder editor of the Indian Anesthesiologists Forum. So I'll be discussing this pertinent topic, which is less discussed, less often discussed, and even less commonly known to the most of the intensives, that it has its own problems. How to restrain the agitated patients in ICU. There are ethical and legal dilemmas with this restraining it is associated. And many of us, we are not aware of this problem, whether this is a problem in itself. And we just accept the way it is. Is it not moving? So, what is restraint? By definition, you can say that restraint is a measure that keeps someone under control. As you want your children to be under control, or your spouse wants you to be under control, but that is not specifically restraint. More precisely, can be defined as restriction of freedom of movement of action. Just a second. I have to. Yeah. So restriction of freedom of movement. And physical restraint, which we are going to discuss, is generally defined as any procedure that prevents person's free body movement and access to his own body by the use of a method that attaches to the patient's body and so that he or she cannot move. So applying handcuffs to a prisoner is also basically physical restraint, because he won't be able to move his limbs to itch if there is itching on his nose. And the same thing applies here in ICU, where we often witness this kind of scenario in most of our ICUs. Most of the patients, they are restrained by tying their hands, wrists, legs over the bed railing or bed frame. So this is a very common sight in most of the ICUs. And unfortunately, we all just accepted, yes, it is common. No, I mean, is there any way out, or is there any problem associated with this scenarios we are going to discuss? So my query to all the audience, do you think that it is okay to keep the ICU patients physically restrained? So yes, no, and sometimes. So you can please post your response in the chat box, and it will be a sort of public opinion on what people think about restraint. It can be acceptable, yes, no, or sometimes. A quick response by audience. I would like them to interact with us, and so that it becomes more lively. So Parul will count the response and will let us know.
So yeah. Far, we are getting a few of them are saying yes and sometimes, and there is a no. 2 and 3 people have said no. Mm-hmm. Sometimes when the patient becomes a physical danger to himself or others, there's a very senior person has responded as it is painful to see a patient under restraints, but most of them are saying sometimes.
Sometimes. So it is a politically, diplomatically correct answer. Sometimes. That means sometimes it is acceptable, sometimes it is not acceptable. So I deliberately put this option because yes and no is more straightforward, and many times we may not be answered in yes and no's. So sometimes, yes, this is basically a correct answer, but then we should know what those sometimes are, where this sometimes is applied, where we should be doing it, and where, when, and how to do it, and when we should not be doing it. So there are grossly 2 types of restraints: physical restraint and chemical restraint. Physical restraint means when we tie the wrists of the patient and leg restraints are applied, chest straps or vests, belts, or in more subtle forms, we apply the high bed rail so that patient doesn't come out or sit with his legs on the side of the bed, or we increase the bed height to prevent the patient to get down. So all these forms are basically physical restraint. And what is chemical restraint? When we give antipsychotics or benzodiazepines or muscle relaxant for the sole purpose, for the only purpose is to control the patient. There can be other indications for benzodiazepines, like patient might be having status epilepticus, convulsions, or the use of antipsychotics, or muscle relaxant maybe in the very, very severe ARDS cases, muscle relaxant may be required. But no, chemical restraint term will be used when the only purpose is to control the patient's movements. Then it is chemical restraint. So talking about physical restraint, concerns about the physical restraint is a very recent phenomena. As I've already discussed, that most of the people, they don't know even that it has some ethical issues associated with it. But despite the lack of the evidence for its usefulness, whether it is useful or not, we are not very sure because evidence are not adequate enough. The use of physical restraint is widespread. It is applied almost everywhere in almost all the ICUs. There is hardly any study on this topic or the report or position taken by critical care societies. So we don't have any guidelines by any society. The research work is not too much, but the use is prevalent. So physical restraint use in ICU across Europe. This is Price study. This was one of the first study on physical restraint use in the critical patients, and it was published in 2010. So restraints are applied to prevent the patient from removing a device. So most of the time we think that a restrained patient, if we don't restrain a patient, he will remove his endotracheal tube or Ryle's tube or Foley's and will remove all the breathing circuits and oxygen mask and whatnot. But this premise itself is questionable because the research on the benefits and burdens of restraint is at best equivocal. We don't have enough evidence. Physical restraint often fails to prevent device self-removal. In spite of restraint in place, patient may be able to remove the devices or like endotracheal tube. And in fact, the restraint itself may contribute to increased rate because if you restrain a patient, patient may become more agitated because the patient will not be able to move his limbs. And more the agitation, more are the risk of removal of devices, including endotracheal tube. And in fact, the evidence indicate that the harms associated with self-removal are exaggerated. So we exaggerate this problem of device removal and we very conveniently restrain the patient. And in the countries where minimal restraint use is used, there are countries where it is legally not permitted and it is less often used. How it is done? By staff education and by environmental changes. So requirement of restraint, physical restraint is much less. And it has not resulted in increased risk or increased device removal. So we have both kinds of data and we have data also showing that it is of no use and it can actually harm. So what are the prevalence of physical restraint? The use of restraint is widespread, we know that. And despite universal agreement about among practice standards, professional bodies, and regulatory bodies that it should not be used regularly, it should be only sparingly used. And it should be reassessed regularly. Every few hours, it should be reassessed. It is estimated that each day, around 56% of ICU patients are physically restrained. More than 50%. In Europe, it has been found that 33% of all ICU patients are restrained, and in Netherlands, 23%, Switzerland, France, about 45 to 50%, in South Africa, nearly 50%, Canada, 76% of all patients on mechanical ventilation. In USA, there is a wide range from 13 to 50% of all ICU patients who are physically restrained. There are data taken from the journal, but in UK and Scandinavian countries, there is a prohibition for the use of physical restraint. And what is the rationale? Why do we use it? We have different reasons. We explain our different reasons for the use of physical restraint. And the most common proposed reason is to prevent the patient from removing devices like endotracheal tube, lines, Foley's, and nasogastric tube, and which can harm the patient, all these device removal. So this is the most common reason that is said for physical restraint. Secondly, to ensure the safety of the patient, because very often the ICU patients are confused, they are in delirium, hallucination, delusion, and maybe very aggressive, agitated, and maybe throwing things around here and there, and it may damage himself or to the healthcare workers also. So safety is also important. This is another explanation that is very often given. Then as a precautionary measure. So physical restraint is applied till your sedatives take over and patient is chemically restrained rather than physically restrained. Once the effect of chemical restraint is there, once the therapeutic levels of midazolam or dexmedetomidine or any other propofol is there, only till that time patients are physically restrained. Another important reason that is said is staff safety, because as the patient is having right to autonomy, right to move his body, medical team also have their rights of working in the safe environment. So for their safety also, sometimes physical restraint may be necessary. Another important point is staff convenience. So staff convenience, because it is very convenient to work with patients if they are physically restrained. A nursing staff can observe 2, 3, 4 patients at a time, and since the patient will not be moving and all the drugs are given, the nursing staff can also have a cup of tea, nice cup of tea, and just sit here and there having with the colleagues, and can be relaxed. So staff convenience, actually, it is one of the very, very common, probably the most common reason for physical restraint. And the contributory factors like critical care units with more beds, with more gadgets, ventilators, with ECMO, with all kinds of device use, they have a higher rate of chemical and physical restraint compared to the smaller units where we don't have too many gadgets and the risk we think is lower. So ICU with fewer resources have fewer types of devices removal as compared to the greater resources. And as per the article published in 2016, there is a minimal association between the rate of accidental device removal and restraint rates. So there is no direct benefit ever established that more the patients are restrained, more the lesser will be the incidence of device removal. No, it is not established. And despite the recognition of its inappropriate use and lack of benefit, it continues to be frequently used in ICU. So you can see that the nursing staff standing there nearby the patient thinks that there are few more restraints that can be applied on the patient. So another question that I would like all of you to respond to is, what is the most common indication for the use of physical restraint in your ICU? Is it to prevent the device removal, endotracheal tube and Foley's? Or is it for staff and patient safety because of agitation of the patient, or is it staff convenience? Be honest. In my opinion, it is staff convenience, but you all are free to give your own opinion in the chat box. Please respond.
Sir, I've received 5 or 6 answers, and all of them are saying to prevent the device removal.
Yeah, that is the most common explanation that is often given. But if you really observe those conditions closely, many times you will feel that probably that is not the only reason.
So I have just got one answer. Okay, we are having a few answers which says that it could be for the staff and patient safety from an agitated patient.
Yeah, but no one has accepted that the staff convenience is also one of
the only one answer, but that says both first and third.
Okay, so whatever response we get, we have to accept it. And my personal opinion is that it is the staff convenience which we actually don't like to accept. But this is one of the very common cause, very common indication for physical restraint, because it becomes convenient for everyone to carry out the treatment and to have a just relaxed duty. So coming to the timing of restraint use, when at what time it is most commonly used? It is mostly used in night shifts. Everyone is drowsy, a bit sedated maybe, and then if you restrain the patient, everyone can relax in the night hours. And many times in the night hours, the nurse-patient ratio also deteriorates. There can be one nursing staff every 4 or 5 beds. So this is another important reason. Who are commonly restrained? More frequently used in men, because probably they are more powerful and during agitation can do more harm. Those who are on ventilator because of this fear of self-extubation, and those who have lines attached with them, central line and arterial lines, because we always fear that patient might pull them out. And when the patient is delirious, is out of control. But who decides in your ICU that the patient should be restrained? Is it the nursing staff? Is it the resident doctor? Or is it the senior doctor or faculty? Decision making is complex and focuses on patient safety. In more than 90% of cases, decision to apply a restraint, they are made by nursing staff without seeking consent or permission from a medical staff, in spite of the protocols advising otherwise. So there may be protocols in your ICU that prohibits or that advises that it should not be used, but then in spite of those guidelines, they are very often used because the decision is taken by the nursing staff. 2/3 of the nurses, they will not speak to their families or patient first before applying the physical restraint. They do it whenever they feel it is required. And more the senior experienced nurses are there, they will take shortcut approach. They don't feel to think it twice, to consider it twice, whether the patient needs it or not, whether I should do it or not, whether the relative should be consulted or not. They will do it within 30 seconds flat. That, okay, patient requires restraint, do it immediately without thinking twice about the repercussions. And the less experienced staff, they will likely to be more analytical. Probably they will take longer, maybe because of lesser experience. and they will think twice whether I should do it or not. So again, coming back to your opinion, what do you think, that the patient's relatives should be briefed or consent taken for a physical restraint? Yes or no? Should we ask
Yes.
patients' relatives that please give your consent, or if not consent, then at least communicate with the relatives that we are going to physically restrain the patient, and do you explain, do you brief them about it? Leave apart consent. Even briefing is not done very commonly. This is what I believe, but then again, every ICU has a different standard of care. And
So most of them are saying yes.
yes, that's very good.
The
That's
response is yes from most of our audiences.
that is very
Again,
hard.
a few more yes.
Yes. This is really very good. That we understand the importance of communication with the relatives. That these things are required. If not consent, then at least they should be told about the requirement of physical restraint. So thank you for your responses. So I would like to have more such responses and quick responses so that we can move forward quickly also. So have you ever thought that physical restraint can be associated with complications? I don't think anyone would have thought it, but there are complications associated, and which is more with the physical restraint than chemical restraint. Patients who were restrained in one article which was published in 2014, patients who were restrained, they suffered more adverse events and they become agitated and over-sedated. See, more you try to restrain a patient physically, more the patient will get agitated, because no one would like to be restrained. No one would like his limb movement to be restricted. And in the because of this thing, they are over-sedated, more sedation we give. So not only we are physically restraining a patient, we are also adding chemical restraint. In 1998, the FDA reported 100 deaths a year from restraint. So I will discuss with you an interesting article which was published in 2012. This article is from Germany, and they analyzed all these cases of death under physical restraint from 1997 to 2010. There were 26 cases of deaths while the patients were physically restrained. And out of 26, 22 deaths were caused solely by physical restraint. All of them occurred in patients under nursing care who were not continuously observing the patients. So it was their duty to observe the patient continuously, but they were physical restraint were applied, and 22 deaths occurred. The immediate cause of death was strangulation, chest compression, dangling in the head down position. So this is very unfortunate. These things can occur, and it is documented. Okay, that patient may harm himself while patient is physically restrained. So the studies, they link restraint to costly complication. If the patient is agitated, we try to restrain him physically and chemically. Then in the process, we sedate them patients, and often more sedate. And more we try to restrain the patient, more the patient becomes agitated. And the sedation also leads to post-intensive care syndrome. The more sedation, more restraining leads to immobility. Immobility leads to delirium. Delirium leads to this post-intensive care syndrome and all those things. So this is a sort of a spider web. The more you try to treat the problem, it gets aggravated. So spider is suggested to be a short form acronym for sedation, post-intensive care syndrome, immobility, delirium, agitation, and restraint. So it's a web kind of thing. You try to control one thing, the other problem appears, crops up. What are the other complications of physical restraint? Most common side effects are increase in heart rate, hypertension, increase in body temperature, impaired circulation because of restraint. Very often, if the wrist is the restraint, patient is restrained through wrist, then there will be impaired circulation in this palm also. There can be skin trauma at the point where the patient is physically restrained. There can be muscle atrophy, limb injury, contractures, fractures, pressure ulcers, and there can be constipation, fecal, urinary incontinence. With physical restraint, patient may be delirious, agitated, or depressed. Patient may be anxious, aggression, cognitive decline, post-traumatic stress disorders. And patient very often, they remember this unfortunate scenario, and that reduces the self-confidence, loss of dignity, social isolation. All these things have been reported to be associated with physical restraint. So post-traumatic stress disorders, it is very common following admission to ICU. It is common, we all know that. But it is more common when there is a use of physical restraint, and also with the use of chemical restraint. Patients with memory of being physically restrained, it was 6 times more, they are 6 times more likely to develop post-traumatic stress disorders. So even after the patient is discharged from your ICU, patient suffers from a mental trauma of physical restraint. It is often underestimated, but it is an important problem. If physical restraints are employed, then the positioning about how tight it is or the placement, whether it is correctly placed or not, it should be checked frequently, very often, from 2 to 4 hours to ensure patient safety, so that there is no unfortunate incident of strangulation or decreased circulation or bed sores or other complications that we have discussed. In one study, the majority of the nurses were not regularly checking whether or not restraints are still in the correct position every 2 hours, which is recommended. And only occasionally they answered the calls of restrained patient, and that makes the patient unsafe. Because of all these problems, there are ethical issues involved. So the freedom to move the body part, it is a basic liberty. Everyone should feel free to move the body parts. And if you restrict it, it is infringement on the patient's liberty. So patients should be the main decision maker for all the interventions, including physical restraint. So who should decide? Ideally patient, but most of the time patients, they are not in the condition to decide. So there can be a surrogate decision maker amongst his relative, he should decide. There is no such thing as general ethical consent. If you think that you have taken general ethical consent while admission to the ICU, no, it will not cover your all the necessary consents, including physical restraint. No, you have to take the consent individually, particularly for physical restraint. Consent can be permissively presumed only for treatment that a reasonable person would not refuse. So we can, if the patient is sick, we very often presume that, okay, the permission should be presumed, consent can be presumed, because a reasonable person will, give his consent to start, say, for example, vasopressors or say catheterization. So many times it can be presumed, the consent, but not always, because a reasonable person probably will not give his consent to be physically restrained. So general ethical consent may not apply for physical restraint. And because of the possibility of self-harm and impaired consciousness, our approach is mostly paternalistic, because as a doctor, with our experience, we think that, yes, we know what is best for the patient. And that is how we decide. To ensure patient safety, many times we have to ignore patient's right to move his limbs. But we decide otherwise, we decide to restrain, considering the patient's safety. So all the restraints are not unethical. Restraint may be permissible if the patient's surrogate decision maker gives consent. So this is a necessary condition to take the consent, but it is not the only thing. This is not the sufficient one. Consent is important, but there are other important aspects also. Because not only consent should be there, the restraint should be medically appropriate also. There has to be some reason medically. If the patient is supposedly not having any devices inserted in him, like tube or other things, and which is not life-threatening, removal can't be life-threatening. It cannot be medically appropriate to restrain such patients. So medical appropriateness is important. And if there are other ways of achieving the same goals, like to keep the patient calm, we'll discuss those other methods. For the intended benefit, then the restraint is unnecessary. If we have other options, then restraint is unnecessary. So it is not medically appropriate, even if surrogate offers the informed consent. So consent alone is not sufficient. Even if the surrogate attendant provides consent, and if it is not medically appropriate, and we have different milder ways of restraining the patient, then it is not ethical. Prohibit the use of restraint simply for the purpose of staff convenience, which we have already discussed. This is one of the most common cause, but it should not be allowed. Just for patient staff convenience, physical restraint should not be accepted. Unless restraints are least restrictive option, and the patient or surrogate has provided consent, and they are ethically permissible, even if they are medically appropriate. So not only it should be medically appropriate, there should be consent, and the more important thing is it should be least restrictive option. So 3 criteria are to be met. Again, repeating the 3 criteria: informed consent is important, it should be medically appropriate, and it should be least liberty restricting means. So 3 conditions are to be fulfilled before applying physical restraints. But then there are exceptions for informed consent also. Safety: when the patient is an emergent threat to himself or to the others, the safety is important. Then as an emergency measure, you may have to restrain the patient. Emergency exception. Say, for example, if the patient is on 100% oxygen, on ventilator with 20 PEEP, and is still unable to maintain saturation above, say, 90% or what, PO2 is still 60. And supposedly patient extubates himself, then the time taken to re-intubate the patient may be life-threatening. So it is an emergency exception. And because patient is likely to die if he pulls out the tube. So, and another this important aspect is if there is advance directive by the patient that whenever required, the proper treatment should be given, then informed consent may not be required, because there are advance directive by the patient as a waiver for the consent. Patient has given permission in the advance directive, then the consent may not be required. Then therapeutic privilege. It is invoked only when there is delay in the process of obtaining consent and it could be harmful to the patient. So ethical permission to restrain the patient, even if the patient or his surrogate has not consented to the application, it is ethically permissible. So informed consent, there are exceptions for informed consent. It may not be required in emergency scenarios. Other exceptions for informed consent, then when it is medically appropriate and least liberty restricting means of preventing his death. If the restraints are emergently needed, there is an emergency, then satisfaction of these two conditions is sufficient. What are those two conditions? Medically appropriate and least liberty restricting means. So if these two conditions are fulfilled, then consent may not be required in case of emergency. So when consent cannot be provided by the patient or a surrogate, the reasonable person rule applies. And what is that? It is based on the idea that a reasonable person would have consented to these procedures. So even if there is no consent, sometimes it can be acceptable and ethically okay also. Most critical nurses, then ethical issues are not only with the patients, it can be there for nursing staff also, because many times if there is physical restraint, the nurses also feel ethical dilemma while deciding on physical restraint. And ethical dilemmas, challenges, tension, they negatively affect nurses' physical and mental health also. They may feel bad while going home that they had to tie a patient and control the patient by physical restraint. So it can be a psychological trauma to the nursing staff as well. Then coming to the legal issues. Basically, physical restraint violates the patient's right to move the limbs. So it is a legal issue. And it can only be used as a last resort, physical restraint, when other methods have been tried and failed. The use of restraint must be authorized by a physician in the best interest of the patient, not by a junior person or by nursing staff. In the United States, there are laws that protect patients' rights with regards to restraint. And the Joint Commission has established its own guidelines, and it requires that all the healthcare facilities should have their policy in place, which should be followed, all those policies, and the staff should be trained on their policies. In case of misuse of restraint, patient can sue you. Okay, so this is important, or lodge a complaint against you. So the summary is that the use of restraint in ICU must be used only when necessary, and it follows a policy of the healthcare center with the orders of physician, and it should be monitored regularly. So there are certain do's and don'ts of the physical restraint, and the physical restraint should be used only as a last resort, as a bridge to adequate sedation. So it should not take more than 10 to 15 minutes that the adequate effect of chemical restraint like sedatives, it is achieved. So typically, if there are no contraindication and if you want to sedate the patient with some drug, only for that time period, patient may require to do physical restraint. And once the effect is there of the sedatives, then we may loosen up all the restraints. So the do's are use 4 to 5 point restraints. In the next slide, we'll see what is a 4-point restraint. If possible, it should be done only in supine position. Restrain one arm above the head and other below the waist, and elevate the head of the bed about 30 degrees and tie restraint to the bed frame and not to the rails. Right. And the don'ts are restrain in prone position. Don't restrain the patient prone position as far as possible, because there is risk of airway complications also. Restraint to the bed rails, it should not be done. It should be done with the bed frame. 2-point restraint like just one arm or one leg, though it is not desirable. And don't tie knots enough tightly that it is difficult to undo. So supposedly, if there is any emergent situation, the nursing staff should be able to do it very quickly, untie the knot very quickly and easily. And don't put pillow under patient's head because there is risk of suffocation also. So this is a 4-point restraint on a stretcher. One arm is up and one above the shoulder, and one arm is down the waist. Head is raised by 30 degrees, and there is proper way to restrain. And a 4-point restraint. Both the legs are also restrained with the bed frame. American College of Critical Care Medicine, they have their own recommendations proposed in 2001 and 2, but the level of evidence is only C. And what are they? That physical restraint should be least restrictive, but the safest environment should be ensured. It should maintain dignity and comfort of the patient. Only the clinically appropriate situation it should be used, not as a routine component. Routinely, patients should not be physically restrained. And they should be assessed if the treatment of existing problem obviates the need. Say, for example, a patient is getting delirious because of pain, for example, or because of hypoxia. Then correct hypoxia or treat pain. Their patient will not be delirious anymore, and there won't be any requirement for the physical restraint. So treat the cause. Alternatives should always be considered. We will discuss alternatives in the next few slides. And rationale for physical restraint must be documented. And whenever you document it, whenever you provide the permission to restrain, it is limited to 24-hour periods, 24-hour period only. And then patient should be reassessed after 24 hours, whether you have to continue this or not. There is a potential to discontinue after every 8 hours. The patient should be reassessed. Can it be discontinued? Monitor for complications every 2 to 4 hours. And analgesics, sedatives, neuroleptics should not be overused as chemical restraints. So how to reduce the incidences of physical restraint and chemical restraint? Is it possible? Yes, it is possible by regularly reviewing the purpose for which we are doing the physical and chemical restraint, and by reviewing the environment of the critical care unit, by education of the nursing staff, by the approach to general management. So coming to the ways by which we can reduce the incidences of PR and CR, alter the environment stimulation, reduce the noise level to reduce agitation, maximize natural light during daytime, encourage patient to remain awake during daytime, and encourage sleep only in nighttime. Lights should be dim, curtains drawn, so that day-night cycle is maintained. Because if it is not maintained, patient will become delirious and will be difficult to control. Keep the objects which are required for daily living close to the head. Use one-to-one supervision as far as possible, one nurse per bed, so that the observation is close and there is no need for physical restraint. And constant or more frequent supervision. The requirement of physical and chemical restraint can also be reduced by proper treatment of delirium and agitation. Like simple problems like constipation, dehydration, hyperglycemia, they're easy to correct in most of the people, which can cause delirium and agitation. Similarly, sensory deprivation like missing glasses or hearing aids, if the patient is conscious and is able to use, and if he doesn't find it, may be frightened and may become agitated. Manage pain, hypoxemia. Maximize daytime activity. Involve relatives with the patient care. Interact with them. Talk to them. Brief them about all the requirement, what is going on. Communicate with the patient relative. It helps a lot in decreasing the delirium. Eliminate bothersome treatment. Remove the Foleys. Remove all the lines when it is not required. Don't keep them unnecessarily. Review medication for any possible contributor, any drug which can contribute to delirium. If it is not required, then stop those drugs. Encourage physical exertion, limb physiotherapy, exercise, mobility. As bed out should be done as early as possible whenever the condition permits. There are alternative strategies by which we can reduce the requirement of physical restraint, like music therapy, massage, therapeutic touch, talking to the patient, explaining what is going on, and maintaining by sleep cycle, increase presence of family and relatives, surrogate decision makers, increase the number of nurses, maximum communication, provide communication aids like pen, paper, involve patient in care planning if possible, involve family and other in the care planning. So there are certain devices available in the Western countries which can be used, and they propagate it as refrain rather than restraint. And these devices, I have not seen it or I haven't used it, but I found it on the surfing that these restraint, they allow the shoulder movements. So there is no less risk of brachial plexus injury. There is less risk of pressure source, and the patient is free to move at, say, knees or shoulder. And whenever required, whenever the patient becomes agitated, the restraint is converted to restraint. And if the patient improves, the restraints are quickly removed. So these devices are available. I don't know how far they are effective, but then it is suggested, at least the manufacturers, they recommend it. So to conclude, I would say that use of unconsented physical restraint on patient is not ethically permissible. It represents an impermissible restriction of basic liberty. There is little evidence of their benefit. And even if there are evidences, its regular use is not justified. Maintain safety of the patient, maintenance of the safety and staff, patient and staff is just short-term restraints. And then patient may be, after all the change in atmosphere and decrease in agitation, it should be removed. Follow due legal process, like taking consent and following the hospital policies. Most morally objectionable is to restrain patient for staff convenience. It is morally objectionable, ethically incorrect to restrain patient just for convenience. And if a unit cannot provide care to a patient without simultaneously violating their basic liberties, then it has no business caring for the sick. So, to conclude, make healing easier, minimize restraint, minimize sedation to decrease the incidence of delirium, maximize mobility and cognition and the spirit to make the patient feel better. And the last question that I would like to put forward is, would you like to change your ICU practice in with regard to physical restraint? Yes and no. And if yes, then how? How would you like to change your practice? Since it is the last slide, so you are free to give your opinion quickly, and then we'll discuss about your opinion, and it will be really informative to get your opinion. So thank you for your patient listening.
Thank you, Dr. Bhatia, for your wonderful talk about the restraining strategies, prevention, and delaying. I think the questions will be answered. My comment is there. Do you find in your ICU also that 50% people are restrained? Because in my place, only two types of the patient, they are put onto the restrainers. One is the liver encephalopathy patient, where we cannot sedate them also. And the other ones are those with a neurological problem, where the patients are agitated, you can't sedate them. So they are put there. And the rest of the things can be taken care by sedation care. Another thing which we have found useful, when we call the patient attendant and make them to understand from their attendant side, the agitation gets lesser and lesser, and then the sedation will help you. So with this small note, I'll ask the audience to put your questions, and Dr. Bhatia will be happy to answer those questions. I think it's a wonderful talk. Yeah.
Again, a wonderful talk, sir. There are a few questions which have come up to us. There's a particular question by Dr. Tilak, that is there any particular reason for one hand to be restrained above the head and the other below
Not particular reason, but just for patient comfort.
Okay, and I suppose the patient will not be able to, get his hands together and pull apart anything. Sir, Dr. Anita Kohli wants to know that bandage is a type of refrain. Is it so?
If you are tying patient's limbs with bandage to, say, bed railing or bed frame, then it is a restraint. Or even if you are applying those bandages above the chest wall so that the patient doesn't move, any restriction in patient movement will be considered as physical restraint. For whatever.
So even the ball bandage, sir?
It is restrained because patient won't be able to scratch his nose. So there is restriction. We may have to, it is not easy to follow all these things which I have said, but then as far as possible, we should follow these things. It is restraint, of course.
And sir, is aggression and agitation common in geriatric patients? And which drug is preferred for geriatric patients? Dr. Sweta Gaonkar likes to know this.
We have to know the cause of agitation and delirium. There are several causes apart from psychological problems. Even patient is having high-grade fever, patient is having hypoxia, or bladder is full, or Foley's is kinked. There are several reasons. First, try to find the reason. Try to find out the cause. pain is very often a cause of delirium. To treat the cause rather than treating the delirium. So if you are treating the cause, if you can find out the cause, most of the time you won't require anything. Then what I have emphasized is change of atmosphere. Allow patient to meet with the relatives. Allow the relatives in. Let them interact with the patient. Patient will feel more comfortable. So there will be harmony.
And in elder group, I found that the electrolyte imbalance is another hyponatremia is especially a cause of very, severe irritation and agitation among the patient. Do you agree with me?
Yes, sir. Definitely. Definitely. Yes, it is an important cause. Even constipation, as I've said, or urinary retention, these are all, any kind of patient's discomfort can cause delirium in patients.
Yeah. Okay.
So there's a comment by Dr. Kinchuk. He says that this practice is very difficult, especially when the convenience is at stake. There is an unwillingness to learn also in the overcrowded government hospital where the nursing staff to patient ratio is very less. So the PR practice is difficult to eradicate. So that's his comment.
Eradication cannot be our target. It is not easy to eradicate altogether, but then it should be rationally done. It should be avoided as far as possible. That is my only submission. So if you try to find out the cause, treat it, and give a minimal amount of maybe sedation sometimes if it is not contraindicated, but then over sedation can again cause post-traumatic stress disorder. So you should be careful. So my point is what we are following is try to take the patient out of the bed as early as possible, expose the patient to daylight. And even if these days there is a new trend about taking the patient even on ventilator to the outside corridors. Right. So that the patient is exposed to sunlight. So delirium will be much less in such patients.
So, sir, Dr. Ratikesh would like to know that is there any medico-legal law to restrain?
Medical legal law to permit you for restraining?
Yes,
so
sir.
There are, as far as in India, I don't think there is any law restricting you or permitting you either way. So you should think in terms of ethics, whether it is ethically permitted or not. Legally, I don't think there is any law which permits or bars you from physical restraint. It is left to the physician's decision. It has not cropped up. It is not even discussed in the most of the societies. So if you consider just ethical issues and alternative methods, the incidence will be much less.
Sir, Dr. Saket Niyogi would like to know, can we use haloperidol in for restraint cases?
It can be used. It is often used, yes.
Yes, sir, Dr. Anita Kohli would like to know that attendants are restricted in ICU settings, so they have very less role to play. So how can we involve them more, or what can be done in such cases?
What is the need for restricting relatives? Why do you want to restrict? Why can't you open them? Why can't you allow relatives? What harm they will do? Rather, their apprehensions will be much less. They will have more trust. They will witness that, okay, my patient is being taken care of. We in our ICU, we often allow them. We generally allow them. Only when they are doing some invasive procedure, we request them to hold on for, say, 10, 15, 20 minutes. Normally, only near relatives, not the distant relatives or not the neighbors. No, only near relatives. We permit them to come inside and to interact with the relative and to interact with patients. This is really extremely helpful.
This is vice versa helpful to the patient and as well as to the attendant also.
Yes,
because they are satisfied and yes, patient also knows that somebody is caring for me. Absolutely. And coming to see me. So that is an important thing. Maybe for 5 minutes, maybe for 10 minutes, but we should allow the attendant to visit at least 2 times a day. You can fix the hours. That is there. Do you agree with me, Dr. Bhatia?
We rather permit them more often and for more frequent. So we have not restricted the timings. So whenever, if something is going on, process is going on, rounds are going, then we request them, okay, just wait for half an hour, then we'll.
That's why the timing can be fixed. So when there is no round and no procedure is being done.
It depends on institution to institutional practice, but then allow them. That is the only thing.
Definitely.
Okay. Sir, there is another question. There is a question by Dr. Niyogi that it is common after neuro and cardiac surgeries and for long stay in CCU. So any prevention for such patients?
Prevention. I mean, all the answers again. I will have to repeat all those things. That patient should be comfortable without any pain, and day-night cycle should be maintained. The same thing. This is the way that it should be prevented.
Yeah. Not so there was
If you are applying a physical restraint, then it will result in more agitated patient.
Right. So there was a comment as well as a question by one of our delegates that is there any relation of restraints on hypocarbia in patients on NIV?
Hypocarbia resulting in what? Physical restraint. See, there will be
Yes, sir.
sympathetic stimulation. Patient can have tachycardia, hypertension, and maybe tachypneic. It is quite possible that patient may be tachypneic, but then there is no direct association found. But yes, if the patient is agitated, patient might be hyperventilating. There can be a bit of hypocarbia, but not severe enough. Not, it can never be very
Right.
severe.
So maybe there was an anecdotal case report or something.
There can be a bit of, because an agitated patient tend to hyperventilate, but for a short duration. Ultimately, patient breathing pattern will not be normalized.
So we have Dr. Naveen Malhotra sir and Agnotri sir with us. May I ask them to unmute themselves? Please comment on whatever comment they would like to make on this topic.
May I
It's
speak,
your
please?
experience. Please, sir. Please, sir. It's an honor to have you with us.
Thanks, Dr. Bhatia, for your nice illustration. But one thing, you have talked only the patient consent or the patient condition which is causing the agitation. What about the environment surrounding him, which is causing more problem to the patient
Sir, I have covered all those things.
when he is not exposed?
I have covered all those things. Environment is very, very important.
You only covered at night. What about the sound volume of the monitors and the discussion, chit chat?
I have covered it in my presentation, sir. I have covered it in my presentation. These things are important.
How much
Extremely
percentage? Have you got any study in that way?
So studies have not been done, but it is well documented that if whatever the music is played near the patient which he likes, or
No, the music is always with the the earphone on.
Yes.
But other patients get disturbed more if the
So
things
by
are
earphones,
that.
yeah, by
Normal
earphones,
patients, those who are not agitated, if they don't get proper sleep due to the reason environmental, the surroundings of the patient or in the ward, that causes more problem to the other patients also.
Yes, absolutely.
Yes, sir.
So my point is, we have to maintain environment according to the time of the day. In the daytime, it should be well lit. In the nighttime, it should be light should be dimmed, and everyone should be allowed to sleep. All the patients. Everyone means patients. Whether patient is less sick or more sick. So that is how we can.
I agree with you, sir. You are trying to correlate with the patient relation with the attendants and exposure to the attendants with the environment. So there should be minimum disturbance to the patient mind. He will have more tranquilized than the giving the drugs itself, chemicals. I agree with you. So that's why my question, surroundings and other things. How you are, Para sir?
Hello, Dr. Agnotri, how are you? Long
I'm
time.
fine. Thank you.
Long
Thank
time.
you. After a long time, I saw you. Thank you.
Are you still in Bhopal?
Yes.
Okay. Thank you. Thank you. Nice to see you after a long time.
That's my pleasure, Para sir. That's my pleasure.
Thank you very
So
much.
we have a
Thank you
very
very much,
novel
Dr.
question.
Bhatia, Dr. Para sir. Thank you very much.
Thank you. Sir.
Thank you so much, sir. I think we have a very novel question or a very novel idea by Dr. Naveen Malhotra, sir. He says, can we plan an RCT on this topic in Indian settings? Sir, a beautifully put up question and a beautifully given suggestion.
Dr. Pradeep Bhatia, sir, heartiest congratulations to you. Yes, I agree with you. You discussed about the sound of the monitors, the unnecessary sound, the gossips, and frequent interruptions by the nursing staff. That's why you suggest that if the things which are of activities of daily living, they should be near the head end of the patient so that he need not be too much worried to pick them up. The importance of hearing aids and the glasses, and if possible, I don't know whether it is practically possible or not, one nurse, one patient, so that the nurse is there and she is vigilant enough to take care of that patient, so there is no need to restrain, and she is taking care of that particular patient. And it's usually happens that once a nurse comes, then a physiotherapist comes, and then some sampling is being done, then suctioning is done, and then the rounds are there, and then the drugs are administered. So patient doesn't get any time. You highlighted all those things that it should be done in a very planned manner, so that patient is, if he is needing to rest, he is able to rest. So those points are very well highlighted, because I was just going across the literature. I didn't find a single study on physical restraint or even restraint, the word, the terminology which you used very efficiently. Is there a school for food for thought to undergo such type of RCTs in our own settings, sir? What's your opinion on that?
Why not?
Or a multicentric studies?
Any kind of scientific study provides us the literature and evidence. So definitely it is a very good idea. And then why not a multicentric study can be conducted? So in which yeah, we can, one group can be, all the environment changes can be provided to one set of patients, and the other, we are simply giving maybe sedatives or physical restraint, and then see the agitation, see the outcome of the patient, post-traumatic stress disorders, everything can be monitored. Yes, we have very few studies actually in ICU, because we have to monitor patients for a pretty long time also.
One Italian study which they have done it, but that's also not very conclusive.
There are not many studies.
They could not come out with any
Not many studies. There are not many.
Not many studies, you know. But we can think of it, and I think the Critical Care Society should also come up forward to discuss, and some guidelines may be issued on this point, you know, isn't it?
Definitely.
Yeah. Okay. Thank you, Dr. Naveen, for having such a wonderful evening, and Dr. Bhatia, thanks a lot for your time. Thank you.
Thank you, sir.
Okay. Thank you.
So see you all next Monday for another important class on a very important topic. And definitely I'll discuss with Dr. Bhatia further how to carry it forward for conducting the RCTs or multicentric studies on this particular topic. Thank you all.
Thank you, Parwal also. Thank you, Dr.
Thank you so
Naveen.
much, sir.
Thank you.
Thank you, everyone.
Okay, bye-bye.
Bye-bye.